pregnancy. Obviously, we're not going to have a PDL or an SPDL with pregnant ladies. So we're just going to talk about some of the things you need to think about when you're examining a pregnant woman. Okay. And then once we finish this, we'll take a break, and then we'll do the lab medicine stuff, lab testing in pregnancy. So you guys already know all this. Professor Reggio talked about it. Use the T-PAL term, preterm, how many abortions, and then living children. Just kind of calculate out your gravido-para. And you're going to find throughout this lecture 20 weeks is like a good point in the pregnancy. Once you're past 20 weeks, you're kind of out of the woods most of the time. So it's at the midpoint. Once you get past that, things kind of change in the pregnancy. So just keep that 20 weeks in your mind. When you're defining nulla gravida, prima gravida, do you guys all understand that? Nulla gravida is a girl who's never been pregnant and not currently pregnant. If you're pregnant currently for the first time, you're a prima gravida. And then, of course, multigravida. Then how you describe the parity. You're still nulliparous if you haven't carried a pregnancy beyond 20 weeks. Again, you're at that sweet spot in the middle of your gestation. So if you haven't ever, you had one, you're gravida 1, but you spontaneously aborted, then you're still nulliparous because you never gotten past that 20-week mark. And then the other thing on this to remember is if you're multiparous, it just means you've had 2 or more pregnancies. It doesn't mean that you've had, it doesn't count if you've had just multiple gestations. So if you've had twins or triplets, you're still had your para 1. You only have 1 pregnancy. So as you'll find too, as you're documenting in a note for a pregnant female, we don't like to say she's in the first trimester or she's in the second trimester. We like to say specifically what week she's in, and it's what week she has completed. So if she's completed 14 weeks plus 3 days, we call her 14 weeks, 3 days. Okay? And you get really, like, when you calculate all that, there's all kinds of smartphone apps, and in your EMRs there'll be little calculators you can use to calculate out gestational age. But as Dr. Gibson spoke about it's already been 2 weeks ago, oh my gosh, 2 weeks ago, it's really important to know exactly how many weeks she is. So documenting that in the chart's important. So nail them down on their last normal menstrual period. The other thing we need to know is when is it considered preterm? When is it considered term? So, and there's kind of some gray area in there because you're counting on the patient's last known menstrual period. So if the menstrual periods are irregular, that date is a lot more reliable. If she's kind of had infrequent, in between spotting, and the last known normal menstrual period may not be consistent. So we have this kind of window of gray area as to when a patient is actually post-term, okay? So technically your term at 37 weeks. Somewhere in that window of 37 to 40 years is considered a term pregnancy, okay? But you're not post-term until you're after 42. And again, that's because there's that, when they leave that 2-week window in there of, well, maybe she didn't ovulate when we thought she ovulated. Okay. And again, with the way we use sonography in pregnancy now, they're able to determine the gestational age very accurately with ultrasound in the first trimester. Large for gestational age fetus, usually these are gestational, mothers with gestational diabetes make really plump, chubby, big babies because they're just swimming around that sugar. And then you've got your low birth weight babies under 25. And a neonate is you call an infant a neonate until they're 28, have been alive for 28 days, which is interesting to me. That first month of their life, they're considered a neonate. But the perinatal period is from 28 weeks gestation to 7 days. All right. Clinical findings of pregnancy. Everybody can name me one, right? Belly. What else?
Amenorrhea.
That's right. What if their periods are really irregular? What else might they complain of?
Weight gain.
A little bit of weight gain. Stiffness. Yep. Okay. They might come in because they're throwing up their toenails. They're pregnant because they're pregnant. Later in pregnancy, you'll get even though your breasts get tender, they're tender first, then they get sore later, then they can leak. So, but the basal body temperature goes up. You also get these skin changes. They call that the mask of pregnancy. This colostrum has to do with the estrogen, and then the linea nigra down the belly. We have some very obvious pelvic organ changes too. We'll talk about in a minute. Who knows what quickening is? I don't know why it's called quickening. I think you probably ought to know you're pregnant before you experience quickening, but maybe you don't. Prima gravidis experience it later than ladies who've had pregnancy before. And then this is a big one. You need to know what week of gestation can you start to hear fetal heart tones. Because if you're following a patient pretty closely and you have no idea what their gestational age is, if you start to hear fetal heart tones, you know they're at least 10 weeks. So again, the breast will be sore early, and then that goes away. It will get larger, one of the perks of pregnancy, if you ask some people. They'll also get veiny, though. They'll get kind of dilated veins, more engorgement. The actual breast itself gets larger, but then the areola and the nipple actually enlarge as well, and they darken. And then there's that. If nobody knows what colostrum looks like, that's what it looks like. It's kind of yellowy. People order this online now.
For immune support.
I would ask the they're packed full of healthy stuff. But yes, you can order this, and you can order breast milk online. Bodybuilders and people drink it. That's weird. It's really weird.
I'm in here,
Okay, so one obvious one is that the uterus enlarges, right? So I don't have to tell you guys that. But you do need to know where you expect the fundal height to be, okay, at whatever week. I mean, 20 commonly is at the umbilicus. 16 is usually about halfway between the pubic symphysis and the umbilicus. So just kind of need to know these general landmarks. But if you'll remember where it's supposed, when is it supposed to be at the belly button? That's, you'll be able to answer any test question probably. That's a good point of reference to use. At 20 weeks, it should be at the umbilicus. And then it should be just at the pubic symphysis at 8 weeks. Okay, so you know how with your SP you kind of had to, she kept saying scoop. You've had to scoop it down below the pubic symphysis. Well, you'll start to feel it kind of at or above if they're beyond 8 weeks of gestation. So you won't have to scoop anymore. The other thing is to know is that, you know, the fundus increases in height, and then at about 36, 37 weeks, all of a sudden it's dropped down. And most women who have been pregnant, or if you've had a friend who's pregnant or mom's been pregnant, you've seen that baby as it engages, just kind of your fundal height will drop. So you just kind of know they're settling in for game time. So you do need to know these old deci names for board questions and things like that. Chadwick's sign, you'll get that just engorgement, venous engorgement, bluish discoloration of the cervix. You'll also have a lot more cervical discharge. So you can have normal leukorrhea cervical discharge, vaginal discharge just from being pregnant, okay? Goodell's sign is just that the cervix is softening and it starts in dilation of the os. That's going to happen closer to the onset of labor. And this one's kind of like, duh. You're really, I guess this Hager was a super smart guy. He figured out that the uterus widens and softens for pregnancy. The other thing you don't think about is, pregnant women already have this overabundance of hormones going on, so they're getting kind of get dinging, start dropping stuff, tripping over your feet, your weight's off balance. But then you also get relaxation of all your ligaments, so your feet spread. So all the ligaments have to spread in order for the pubic symphysis to spread. Because we got to get, a 10-centimeter head through there. So you'll start to, they may even get like pubic symphysis pain. They'll get round ligament pain across the uterus here. So just those ligaments just start getting kind of lax. Their arch in their foot might drop. They are bigger than a house. You can also have uterine contractions all throughout pregnancy. I mean, the contractions of the uterus itself is helping to just kind of soften and stretch and prepare the uterus for labor. So you might have them early on, as long as they're not real painful or regular, they're not a problem at all. It's not until they become frequent, of long duration, and increasingly more frequent and increasingly painful that we start to worry about the onset of labor. So how do you diagnose pregnancy based on a history? So obviously, most patients are going to come in and say, oh, I took a pregnancy test at home, and I'm pregnant, right? But if you don't have that available, you're just using the last known menstrual period, there's actually an equation you can use and talk about in a minute. But you always have to consider the regularity of the cycle. If the cycle's irregular, that's not as reliable, and you just want to date it with an ultrasound in the first trimester. I would hope that by the time you're palpating the uterus and palpating a fetus, that we already have an established diagnosis of pregnancy. Your urine pregnancy tests we'll talk about more in lab medicine, but again, most patients are going to come in already having done that at home. But you always confirm it with one in the office, because the medical grade ones that you buy are much more sensitive than the ones you just pick up over the counter. And again, you don't really know the technique that they're using or things like that. So it's just more reliable to just, even if you're sure they are, confirm it. Okay. Yes?
What is LMNP stand for?
Last normal menstrual period. So again, at what week can you start hearing fetal heart tunes? It's at 10 weeks. You've got to know a normal rate, okay? And everybody will say, well, if it's a girl, it's faster. If it's a boy, it's slower. I don't think there's anything that has proven that. Or if you have heartburn, you're going to have a baby with lots of hair on its head and things like that. But you do need to know the normal range on your fetal heart tones. You would check those every time. And when you're in your women's health rotation, you may be doing those a lot, just for practice and things like that. So just check. Those are quick and easy. Most of the time, the medical assistant or the nurse checks it for the doctor every time comes in. So just easy. Check it every time the patient comes in. Ultrasound they use at the bedside now so much that we just get really spoiled with our ultrasound. Probably do too many of them, but they're fun. You see the baby, floating around. They're more fun when they're little because you can see them moving around more. Then they get real squashed in there and they don't do much. It's not so fun to watch. You do need to know that you can see a gestational sac amazingly at 4 to 5 weeks of gestation. Now that's 2 weeks after missing the period. Excuse me. That's 2 weeks after ovulation. Okay? So date of the last known menstrual period was 4 weeks ago. So, and that's crazy to me. But it has to be done transvaginally, okay, to be able to see the gestational sac that early. The other amazing thing to me is that you can see the little heart beating at 5 to 6 weeks from the last known menstrual period. Again, with a transvaginal. And then by 10 weeks, that's a 10-week fetus. It starts to sort of look human. I mean, still not quite. That could be a chimpanzee, I'm not sure. But it starts to look more like, let's say it look more like a primate. But. Okay, so I'm going to tell y'all something right up front. I didn't do a lot of prenatal visits in my career, but the good thing about that is you're getting the very basics of how to do a prenatal exam, because I didn't do a whole lot of these. So again, that's your first visit. Obviously you're going to get your very detailed history. You're going to do your complete physical exam, including a pelvic exam. That may be the only pelvic exam true with a speculum pelvic exam they get the entire pregnancy. Okay, so pelvic exam, breast exam, figure out the gestational age, estimate the estimated delivery date, get your first ultrasound, do all the laboratory tests that we're going to talk about in the next lecture, and then assess for any high-risk situations. Okay. What are we going to be thinking about in the history? I mean, to me, this is all real intuitive. I don't know how intuitive it is to you yet, but it'll become intuitive. You want to know, number one, when was the last normal menstrual period? Have you been pregnant before? What is your situation at home? Were you intending to be pregnant? You need to kind of get a feel for that. Most of the time, that's going to come out early in the conversation, but establish that trust. Is there any chief concern? Is your chief concern, I've had a miscarriage before and I'm scared? Is your chief concern, I didn't want this baby, I'm in an abusive relationship? Very important to get the chief concern, okay, at that first prenatal visit. Are you already thinking about birth plans? Are you having any symptoms that we need to address today? Anything like that. You definitely need to make sure there's no vaginal bleeding, screen for nausea and vomiting, screen for abdominal pain, things like that. And to get a good obstetric history, you need to get all the, gravidopera, T-PAL, have you ever had a C-section? If you had a C-section, where was your incision, how was it done, how long ago, things like that. And then of course, did any pregnancies end before 20 weeks? So that would already make you a little bit worried for her to be high risk of another miscarriage. Have you ever had sexually transmitted disease? You got to think about PID. Right off the bat, first thing you want to do is make sure the little gestational sac is where? In the uterus. Right. It seems really simple. Like the first thing you need to be sure about. Okay. Especially if they're coming in with bleeding and pelvic pain, but for everyone really, you make sure that the pregnancy is inside the uterus. So just a bit more about the history, anything that can relate to putting the patient at high risk, like epilepsy, heart disease, severe diabetes, severe autoimmune diseases, ever had a prior blood transfusion, things like that. Did you have an IUD in when you got pregnant? Any type of abdominal surgery would put, especially related to the pelvic organs, are going to put her at higher risk of ectopic, so get a good past surgical history. And prior C-sections, again, we said before. And even an appendectomy, if done open or done by a hack job, can give you tubal scarring on that side and things like that. So any kind of lower abdominal surgery might create adhesions. Most people that have had small bowel obstructions or had prior adhesions, they're going to know and they're going to tell you. So definitely ask about that. What things should we be thinking about with the family history? I mean, you should already be playing PA geneticist right off the bat, right? When you have a pregnant female, what do you want to ask her about as far as genetic things that you want to screen for in the history?
Cystic fibrosis.
Cystic fibrosis is a big one. And we've talked about it in every module. What part of the male anatomy does it give? Why would it cause infertility? We talked about it in infertility.
The vas deferens.
Absence of the vas deferens. So it can contribute to infertility as well. So does twinning run in your family? Whose family has twinning? I mean, that's what, fifth of the class? So my maternal grandmother had 10 kids in her family, and 4 of them were 2 sets of twins. And then my mom, my grandma didn't have any twins, but then my mom had, my sister was actually a twin, and we lost one of the twins early on. So it was like, it skipped me though, I didn't have twins. It was one of those things where you're like, man, it'd be cool to have twins, you know, and then you have one, and you're like, we were stupid. What were we thinking? That was not smart. That was somebody who had never had a child before.
Is it true that it skips generation?
That's what I've heard.
So your daughter?
My daughter. But yeah, it was like, man, we were not smart. One is hard enough. Okay. So you do want to screen them for, of course, what do we talk about in every social history? Smoking, alcohol, tobacco, everybody, because there are known risks, right? Everybody knows about fetal alcohol syndrome. We talked about that at the beginning of the year. IV drug use, but also ask about the partner's drug use, because partner drug use puts them at possibly in a dangerous situation, and possibly can affect pregnancy more than just conception. It could affect her safety and her psyche for the remainder of the pregnancy. Oh, and you get to do a pedigree. Three generations like that, right? Okay. So you do need to do a quick psychosocial screening in all of your pregnant ladies, okay? These are the tough questions, you know, and you have to find your way to kind of weave them in, but when you're asking, maybe don't need to ask if they're sexually active, because they're pregnant, so you know they are. But instead you could ask, you know, do you feel safe in your home? Who do you live with? Are there any other people in the home with you? Just things like that, we kind of weave in some questions to make sure they're safe, and they're not being abused or anything like that. I can't remember which guest lecturer talked about it, but that is the most common time for a woman to be abused. Yeah, Dr. Gibson, it is when she's pregnant. If you're going to be abused, it's probably when you're pregnant, which is sickening, but it's true. And then the recommendations also ask that you screen them, you know, every trimester. So, you know, she might have been peachy keen first visit, and then you get to see her for 6 months. And then she comes back a wreck, and she didn't come to any of her other visits because her spouse is abusing her. She's been battered and she hadn't been in. So screen. So here is your little equation you can do to calculate the estimated due date. You just use the last normal menstrual period and 3rd grade math, and you can get it done. So today, September 5th, right? 4th. Okay, so let's say today was Kathleen's first day of her last normal menstrual cycle. When would she have her baby? Today was day 1 of her last normal menstrual period. Yeah. So you just June. So you go to June 4th, and then you just add a week onto that. Then they also make those little wheels. You'll see those little wheels in the room where you can just dial, match up the dates, and last normal menstrual period will give you the EDD. And then, of course, you get that date, you think you know when you're due, and then you get your first ultrasound, and you're like, oh yeah, it's way off. So if somebody asks you what's the most accurate way to determine the estimated due date and the gestational age, it's always going to be your first trimester ultrasound. The first trimester ultrasound, where they actually measure the fetus and the link, we'll get to it in a minute. That's actually the best way to determine gestational age. Everybody knows how to tell the difference between a nulliparous os and a multiparous os, right? Because your SP had a nulliparous os, yes. That's how you measure fundal height. So when you measure fundal height, you place the 0 centimeters on the pubic symphysis. So you just find the top of the pubic bone and then you measure upwards from there. So you measure in centimeters above the pubic symphysis. This idea of pelvimetry, you know, like they're going to measure if your pelvic outlet is big enough for a baby to come through, they don't really do that anymore. There are ways to do it, and there are guides to go by to tell what the risk of a patient not being able to labor is based on just the shape of her pelvis, but the recommendation now is to just let the woman have a trial of labor and see if it'll happen before you just decide based on pelvimetry that she's not going to be able to birth the baby. So everybody gives at least that first pregnancy, the narrow pelvis, they let them try to have a baby. And Dr. Fletcher may talk about that more when she lectures later this week. The land of Oz. No, nobody likes that. Cheesy. That's a pretty, I mean, that makes it very obvious to see that it's multiparous. It's just kind of smiling at you. It's smile or frown, but it's not a circle. That sucker's been stretched out. At least once, maybe twice. Okay, just some other things to consider in your first visit. You should always do a breast exam because you want to make sure the pregnant lady doesn't have what? Big breast cancer, right? So make sure breasts are clear. Do check blood pressure at every single visit. You're going to do that with all of your patients though, right? And check blood pressure every visit, but definitely in your pregnant lady. So what are we screening for with that? Preeclampsia, definitely, or just hypertension of pregnancy. So very important because the blood pressure can change quickly in people that are getting sick with preeclampsia. So you don't be like, oh, her last 4 or 5 blood pressures were fine. We don't need to check it today. Yes, you do. You check it every time. And then again, always do the fetal heart tones. And then always measure the fundal height once it's coming up out of the pelvis. All right, so we're going to talk more about laboratory testing. Don't freak out. Don't measure this. Don't memorize this. But you need to know that these are the things you need to be thinking about, that there might be a high-risk type patient. Okay, if they have uncontrolled, a lot of them are going to be very intuitive to you. They have a known history of cardiovascular disease, that like a rhythm irregularity. They have atrial fibrillation. I mean, and you guys are going to see a lot more older patients. I mean, the people that are getting pregnant later and later. So they've had a blood clot, or they've had a seizure disorder. Their diabetes is way out of control. You guys have all seen that, right? At Good Shepherd. They currently have cancer. I mean, that would be pretty terrible, but that's one of the things they list would put you at high risk because you're very hypercoagulable anyways when you have cancer. Any family history of some type of known genetic disorder, Turner syndrome, Klinefelter's, cystic fibrosis, all of those things we're going to consider for genetic counseling for these patients. Okay. What things in the obstetrical history are going to put your patient at high risk? Okay. I'm not so sure I would refer every RH negative lady for like a specialist consultation because I'm RH negative, but it's just something you need to be thinking about. They'd be at risk of hemolytic anemia, and we'll talk about that more in lab medicine. Any past pregnancies where they've had maybe a cleft palate or just any kind of structural abnormalities, spina bifida, something they detected on ultrasound. If you have your higher order multiples, so twins, probably a general will feel comfortable to take care of that, but triples, quads, and on up, they're gonna go to a high risk gynecologist or obstetrician. And then we'll talk about disorders of amniotic fluid here in just a little bit. Okay, what do you need to tell them at that first visit about their nutrition?
Stop drinking.
Okay? The entirety of pregnancy only requires an additional 80,000 calories, okay? So your calorie need, your caloric need on a daily basis during pregnancy only goes up by a maximum of 300 calories. So when you say you're eating for two, it's really just like an extra snack. You really don't need that much more, and especially if you're already overweight. You don't really need to increase your caloric intake at all. Here is your recommended weight gain, okay? If you're at a normal weight, it's recommended that you gain about 30 pounds, okay? If you're already overweight, you need to gain about half of that. And if you're obese, you don't need to try to gain any, because pretty much your uterus and your baby and your fluid is already at your what you need to gain. What are the risks for obesity? They're actually bad. I mean, the research is ongoing in this field, because guess what? Americans are getting fatter and fatter and fatter. But they're higher risk for having a C-section, they're higher risk for preeclampsia, they're higher risk for gestational diabetes, they're higher risk for hypertension. So it's like all of it. If you're overweight to begin with, you're gonna have more trouble. So you can tell them they need 300 extra calories a day. They need 1 gram per kilogram of protein per day. They do need to take iron, because why do pregnant women get anemic? Yeah, parasite is sucking all of your iron out of your body too, but you're also volume overloaded as well, and so you get all this volume, so your hemoglobin and hematocrit actually by percentage goes down a little bit. So, but yes, your iron needs do go up in pregnancy, and then it's not so much that you really need to take extra folic acid. It's just that we want to make sure that you've got plenty on board, so you don't get neural tube defects in your baby, and that's fine with things like that. So they do recommend iron and folic acid supplements. And all those prenatal vitamins will meet those minimum requirements. What do you tell your pregnant patient, though, when you're recommending that they go on an iron supplement?
Constipation.
What's it going to do to their constipation? They're going to really need to make sure they're eating lots of fiber, drinking lots of fluids, because it does tend to slow you down. Okay. So as I was looking for, what other nutritional counseling should you be giving ladies? This is just kind of the ACOGs, how we feel about what our pregnant ladies should eat. They pretty much say eat what you want in reasonable amounts, with one caveat, which I'll tell you in a minute. You don't have to restrict your salt, just salt to taste. You do need to make sure that your socioeconomically ladies have access to food. If they don't, you might try to get them some food stamps or something. Of course, we want them on with their weight gain, which we've already talked about. You want to explore their food intake at every visit or two. Just make sure their appetite's okay, they're eating plenty, they don't have any questions or concerns. The iron, the folate, and the key with the folate too, especially in your young females who are wanting pregnancy, they need to be taking the folic acid ahead of time, okay, to help prevent those neural tube defects. And they do recommend that you screen them again for anemia between 28 and 32 weeks. And we'll talk about that again, and we'll have medicine. What do we tell them about caffeine and alcohol? We tell them that caffeine in a minor amount, even on a daily basis, has not been shown to put the fetus at any risk at all, okay? Most ladies, I shouldn't say most, a lot of ladies will just stop caffeine, but they don't have to. If they really like tea or coffee, even occasional soda pop, they can still have that. You just don't want to get over the 500 milligrams per day. No Monsters, no Red Bulls, things like that. Okay. I usually tell patients, if God put it in the ground for you to drink it or eat it, it's probably okay. Like tea leaves, coffee beans, things like that. If the Coca-Cola plant is putting it together, it may not be as good for your baby. Alcohol, I would just recommend that you stop. There's no benefit to it. It has been shown to be bad for the fetus if you're even taking 2 ounces a day. Okay, and that's not a lot. If you're an alcoholic, that's a tiny amount. So it's better to just recommend they don't. But if you have a female that comes in and says, but I have this wedding I have to go to and they're going to toast, and can I just have a glass of champagne? Yes, you can have a glass of champagne. Yes, you can have a glass of wine with your mother on her birthday. There's no risk in that at all. You have 1 glass of wine every once in a while you're pregnant. Okay? But there's just no benefit to it, and if you don't rely on drinking it, just don't drink it. But if you're celebrating something, it's just fine. What food you do need to tell them to avoid is they need to monitor their mercury, okay? So most of the types of fish that are high in mercury, we don't eat in landlocked Oklahoma in high amounts anyways. How many of you have had swordfish in the last month? Mackerel, anyone? Shark? No? But who's had canned tuna? A lot of people? So it's fine to eat the canned tuna, you just have to keep it under 6 ounces or less a week. But if it's any other fish, they can eat 8 to 12 ounces of fish every week. Okay. So I didn't get a radiologist to come talk to you guys about ultrasounds for this module, so you get me. You guys want to take about a 5-minute break, or you want to just roll through this one? You want to roll? Keep rolling, and we'll take one before the lab in. Okay. If you need to get up and go potty, just feel free to step up and go. So you do need to know why you do ultrasound in pregnancy, okay? How many of you knew you could date the pregnancy with ultrasound? Okay, get the estimated gestational age and the estimated delivery date. How many knew you could screen for aneuploidy? You can look for chromosomal abnormalities.
What does that mean?
Chromosomal abnormalities. Okay. Evaluate fetal anatomy. That's kind of a no-brainer, right? You can also measure the cervical length if you need to. Just to kind of check for cervical competence, things like that. And then monitor the fetal well-being. If the mother comes in and says, I haven't felt my baby move in 2 days, first thing you're going to want to do is look in there, right? We're going to try to get fetal heart tones, and we want to look in with an ultrasound. So early on in pregnancy, it has to be done with a transvaginal ultrasound. My sister's a sonographer, they call this the magic wand. Because early on, that uterus is no bigger than a normal size uterus, so you're really not going to be able to see much from the top down, so you want to look straight up through the cervix with the transducer intravaginally. Things are pretty tiny, but you can see these things really, really early on. I mean, if you've just missed one period, a couple of weeks, you've missed a period 2 weeks ago, you'll be able to already see a gestational sac. Okay. You'll also be able to see, you can see the 2 asterisks. If the pregnancy is intrauterine, okay, a good way to tell it on ultrasound is they'll have these 2 layers of the endometrium. You'll have the inner layer, and you can kind of see where there's a separate outer layer. So, and then that's the little embryo right there. Just looks like a blob at this point. And then the yolk sac looks like you would think an egg yolk would look like, right? Now, this is a pregnancy where it's not supposed to be. So this one's good because I know sonographers, I'm like, oh, I like that colored lines, tells me where everything is. So as you can see, here's these two circles of the uterus up there. Well, where's our gestational? Oops. Yeah. And you really can't see much. There's not a lot going on yet, but you can see that gestational sac. Here you can see that the embryo is actually in the tube. So you definitely, obviously, can check for viability of the pregnancy early on. First thing you want to do is make sure it's actually in the uterus. And so you've found it's in the uterus, mom's doing fine. Next time she comes back, you just see crown to rump length. They have algorithms that'll calculate out based on the size what they think the estimated due date is. But as they get a little bit older, you can actually measure parts. So most accurately between 13 and 20 weeks. When they can measure all of these parameters, it'll give you a better estimated due date. So that's the biparietal diameter. If that's all you can get, that's a good one. That's the best of all those measurements. That's the best one. And so these algorithms that the sonographer puts in, it just calculates it out for you. They just put in the measurements and it does all the math and pumps out a due date. Once they get older than 24 weeks, it gets a lot less accurate. Okay? So your sweet spot's there between 13 and 20 weeks. So they measure the biparietal diameter, so just the little baby skull bisected that way. And then the actual head, they'll calculate the head circumference using that diameter. And then the abdominal circumference, and then the length of the little femur. And so a good sonographer will be able to just position this around to get all the different angles to get the measurements they need. So they'll measure the distance across the abdomen, and then they'll measure that little femur bone. And this is about at the stage where it looks like that little primate. I wouldn't say human yet, but they kind of have a big head and their little teeny legs and little kind of flippers. Now, as it gets a little later in pregnancy, the volume of the amniotic fluid becomes more and more important just because it's a sign of something bad could happen if the fluid volume is either too great or too low. So you're just it's just one of those parameters they measure just to be staying up on things to make sure they're not able to predict anything negative. So if the volume is under the normal threshold, we call that oligohydramnios. If it's greater than, we call it hydramnios. It used to be called polyhydramnios, but really just hydramnios, which puts babies at risk for preterm labor, birth defects, cardiac abnormalities, things like that. There are 4 different fluid pockets you can measure, but they basically, again, the sonographer just measures the different pockets, plugs it into an equation in their computer, and they pumps it out for you. Not the fluid, pumps out an index. You also, at this point, you're in the second or third trimester, you're really wanting to know where the placenta is. Makes the obstetrician feel a lot better if that placenta doesn't grow little feet and climb up the wall, remember? But it starts to move up to the top of the uterus, or at least to the side. You don't want that placenta anywhere near the cervical os at all. That patient's going to be at risk. Hear about, well, I had to go on bed rest towards the end of my pregnancy or something. Their cervix was dilating, or the placenta was too close, or they were bleeding. things like that. So if that's placenta is sitting right over the weight of that fetus, it's going to put the woman at risk for placenta previa. And I'll tell you this right now, that if Dr. Gibson talked about it, you've got to be able to know clinically the difference between previa and abruptio. So when you start going back through her lecture, the board questions love the previa and the abruptio. So no, definitely know that. One's painless, one's not. Okay. At this stage of the game also, as the pregnancy is later, you're going to be looking at the cord itself as well. So now the cord's big enough so you can actually measure it. So this is another sign of could something be wrong with this fetus. The cord should normally have a large vein and two arteries. So in a cross section it should look like that. We know, and you can pull all these statistics up and read them as far as the percentage, what percentage of this predicts that and things. All I want you to know is that if you see a 4-vessel cord, it's very rare and it can be associated with congenital abnormalities. That's all you need to know. If you see a single umbilical artery, it's the most common abnormality seen, and it's almost always associated with major congenital malformations. Okay. So you wouldn't think just intuitively that you could count the number of vessels in the umbilical cord to be able to tell, predict what's going to happen to that fetus, which actually can. So if you can see that early on, it can be a sign that you need to go. Well, probably need to refer it to a high-risk OB, but this something could go wrong. Yes?
Is that like cord insufficiency?
No. There are a lot of other cord problems. You can have too much coiling, not enough coiling, insufficiency, all kinds of different things. This is early on. So this is just a problem with the basic structure of the cord. Now, could one of these basic structures later cause insufficiency as the fetus demands more blood? Possibly. So if you see something on ultrasound, or if your patient comes in and says, I haven't felt my baby in a couple days and they're freaking out, you can get a biophysical profile to just very quickly and accurately evaluate fetal well-being. Okay? A sonographer can do this, a trained obstetrician can do it. I'm sure there are PAs and OB that do this, because you can go to separate training and get trained in sonography. So you're going to you're going to do a fetal heart tracing, which we call a non-stress test. So when you hear non-stress test, it's basically just measuring the fetal heart tracing itself, looking for accelerations and decelerations. And you'll get more on fetal heart monitoring later. They're going to measure the amniotic fluid volume. They're going to measure, you can actually see the fetus breathing. Who has been pregnant and seen their baby kind of gulping at amniotic fluid on the ultrasound? Yeah, so you can actually see them kind of making breathing motions. And then fetal movements, they just basically sit there and watch for the baby to move. Hiccups are considered breathing activity. That's cute. Anybody's baby get hiccups when they were pregnant? Yeah, that's really wicked. And then the fetal tone is just basically how their limbs, whether they're limp and not moving, or whether they're really, contracting. So you can imagine if somebody has good muscle tone, they're going to, be able to pump their bicep up. But if it's a sick fetus, it may just be flopping around in there and not have good tone. Does that make sense? So people get kind of crazy with their ultrasounds now. Like, you can basically go get an intrauterine picture of your baby before your baby's born. I don't want to hurt anybody's feelings. I think all that's kind of silly. Like, you're going to see it when it comes out. You need to go pay all this money to get a 3D, 4D, HD, We can do HD live, just watch them flopping around in there. I don't know. That was never, and it just looks like a baby. Like, I don't know, I'm kind of crass that way. Like, it just looks like another newborn. I was kind of more always like to look at the ones that look like aliens. That's much more fun. Okay, everybody all right? Keep rolling until we get through this? Okay. So as you follow up with these patients going forward, do not memorize this chart. This is just for you to reference, like what's going on development-wise at each stage, okay? And particularly what develops last, you know? Your kidneys are good to go at about 36, but you're still working on your lungs, you're still working on your external ear for some reason, and your nervous system. So just kind of shows you that they're cardiac. Where's cardiac? I mean, there's esophagus, or no, they're still their lungs. Wait, where's their gut? Intestines. I mean, their gut's done here. Heart is done right there. It's kind of crazy to think that early that most of that development is complete. And here's where they lose their flippers. Right about there. They all start out with flippers. Okay, so 12 weeks is, let's see, well, I mean, we're trying to have that chart up too. But 12 weeks, you kind of have a human-like baby. I mean, it's pretty tiny. This one was a spontaneous abortion. I mean, it's just about a couple of inches long. You don't really have a belly, you know. Here's where they're measuring crown to rump. Here. And you can see he doesn't have his flippers anymore. But you can also see here the uterus hasn't even really come up very far out. By 8 weeks, it should be above the pubic symphysis, which you can see it is, but it's still kind of right there with the bladder. But you can tell by that picture that why you start getting bladder symptoms so early. It's not just the hormones, that little thing is sitting, honestly, right on your bladder. So here's your halfway point. Again, at 20 weeks, we're starting to feel like we're rocking and rolling a little bit, kind of out of the woods. Fetus is active a lot at this point. This one, this picture is from a book that was published a long time ago. I can't even remember. My mom had it when I was little.
It was like a Time magazine. They did like a special.
Yeah, the miracle of something or lot. I don't remember, but. I had all those intrauterine pictures of the fetus that he was sucking his thumb there. So this is at 20 weeks. By this time, the fundus is at the umbilicus, right? You're all going to memorize that. Okay, so once you get to that 20-week mark, you're going to start seeing the patient once a month. Okay? You're going to measure the fundal height each time they come in. You're going to do that for about 2 more visits, and then once you get them to 28, that's when you start seeing them every 2 weeks. And then once you get to 36, you're going to check them weekly. Okay. What are you checking every visit? What we already talked about. Blood pressure and fetal heart tones. Asking them what kind of questions. Are they safe? And you're bleeding, you have pain, you're eating okay, some headaches, blurred vision, any of those kind of things. So just kind of screen them every time they come in. So once you get to 36 weeks, technically you're ready to go. You can have a baby at that point at any time. So you're checking for cervical changes. That was the most disappointing part with the first pregnancy. You go and you're like, yes, I'm going to be dilated this time. Nope, still not. So when you get to that 28-week mark, baby's about the size of an eggplant. They're starting to get, and you can see starting to get a little cramped up in there. Getting a little tight. Their feet end up by their face eventually. But at 28 weeks, A normal, healthy neonate has 90% chance of survival, okay, if they were to be born at that time. That's pretty high. I'd take those odds. So here what we're talking about, maternal blood pressure, weight, we didn't say weight, we're not gonna weigh them at every visit, check their symptoms, get their fetal heart tone, assess for fetal activity, just ask them if they've been feeling the baby move. You can just check the fetal growth without doing an ultrasound, just check it by whether their fundal height increased since the last visit. That also assesses their amniotic volume. You know, the fetus is growing, but the volume's going down, the fundus isn't gonna raise as much. So that fundal height is pretty important. It seems kind of, why are you doing this again? It actually gives them information. And then not till 35 to 37 weeks, we'll do the group B, and we'll talk about that more. Okay, 36 weeks, getting cramped up in there. So is they having a boy or a girl?
Boy.
Boy. Boy. Can I please have a boy? Everybody see it? I can't worry about you. And at this time, at 36 weeks, it's essentially 100% survival rate. It's looking more like a real baby at that time. It's getting chubbier. We're wrapping up the lung development. Again, this is just your fundal heights. Again, just a reminder that it's going to drop. After 36 weeks, you're going to have actual drop in fundal height. It's not bad. It just means that the baby's engaging. Okay, difference between effacement and dilation. Everybody talks about dilation, right? And that's pretty obvious. It's just the cervical os widening. Effacement, though, is you have to see how thick the cervix is. You have to, well, you have to obliterate it. I mean, so the length from here to here has to go somewhere. It doesn't just, all of that doesn't just widen. That inner part of the internal os just gets pulled up into the endometrium or the myometrium as the uterus expands, okay? So, as you can see on this picture, this just starts slowly over time, these fibers are just getting taken up into the uterus. It just leaves you with the bag. The bag just kind of hanging out there, ready to go. So to me, the effacement makes a lot more sense when you talk about it being pulled up into the uterus. Your uterus is getting very large. So as it enlarges upward, it's just pulling the top of the cervix up with it. And then the external os is just, when we're ready for go time, it just starts spreading out. So 10 centimeters is the bagel. I mean, it's like, oh, this makes a lot more sense when I look at it this way. Baby said, has to go through there. So about the size of a big bagel. When we document effacement, as the cervix starts to dilate, you kind of feel if it's getting softer and it's kind of not as thick. I mean, remember on your SP, it was kind of real thick and muscular, kind of, it's not even really muscle, but it just looks more, I don't know how to describe it, more substance to it. But as it starts to efface, it just kind of gets a little bit softer and starts spreading a little bit. So it's not necessarily that you can get your finger in the hole, that's dilation, but that the cervix itself starts kind of getting to be more mushy. So we document that 0 to 100%. And it's going to be based on what you checked last time. So you're not going to be able to just feel the cervix for the first time and be like, that's 73.4% efface. I mean, you just have to kind of compare it to what it was last time. Last time it was 0% effaced. This time it's 25% effaced. Next time it's 50% effaced. So you just kind of have to compare it to what she was the time before. And the dilation's a little bit more numerically makes more sense. So 1 finger in the os, 1 centimeter. 2 on top of each other is 2 centimeters dilated. 2 fingers side by side is about 3 centimeters. 3 fingers side by side is about 4 centimeters. So, I mean, again, you're ballparking it. And then, I mean, that's about 9 to 10 centimeters. So if you can get your thumb and finger across the baby's head, you can feel the cervix as that spread out. It's about 9 to 10 centimeters. It's the miracle of birth. Okay, so this is just another way to look at it. So in this first one, they're not effaced or dilated at all. The cervix is still thick. Then you start to see that it's completely effaced. It's thinned out completely, but it's still pretty much closed. I mean, maybe 1 centimeter. And you see your 5, and then you see baby's head. Don't push yet, ma'am. Wait till the doctor's here. So, has anybody heard of the station, like, say, cervical effacement, dilation, and station? Station is where the baby's head is in relation to the pelvis. So they use the ischial spines, because you can kind of feel those right there, kind of your butt bones down there at the bottom, not the coccyx, but your ischial spines. If you can feel the baby's head right there at the ischial spines, it's 0 station. If you still have to reach in a little bit to feel, then you just have to judge the -1 station. If it's above the ischial spine's negative value, as it's starting to sag below the ischial spines, it's positive value. When they're the baby's head is at the ischial spines, and they're 10 centimeters dilated, she's ready to go, she's ready to push, and fully engaged. The other thing is, when they come in labor, and they're 100% effaced, they're 10 centimeters dilated, but their station has not changed or progressed, that's going to be highly predictive of dystocia or labor that's not progressing, and you're going to have to cut the baby out. So station is important. What do you need to tell your patients that in those final weeks, what kind of symptoms they need to be watching out for? What's our red flag signs? Obviously, if their water breaks, they need to call you immediately. How do you tell if it's pee or if it is amniotic fluid? Yep. They smell like pee. You feel like a rush of water coming out. You know, pregnant ladies will pee on themselves just because they're big. They got to get there quick. Their bladder is about that big. But if they just feel like just a bunch of water gushed out, obviously they're water broke. But sometimes when the amniotic fluid is leaking, it's just dripping. So they make little tests you can do at home, like a litmus test to see if it's amniotic fluid and things like that. But just check them and see if they're in labor. So obviously if they've had bleeding, if they have bleeding, call. If you stop feeling your baby move, call. If you start swelling up, please, for the love of God, if you have a seizure, call. Headache, blurred vision, things like that, which are signs of preeclampsia. Any kind of fever, chills. All pregnant ladies have back pain, but if they just all of a sudden get an increased strange back or pelvic pain, they need to go, you need to see them that day. And then any other, like if they get pneumonia, if they get appendicitis, because it happens. If they get gallbladder, acute cholecystitis while they're pregnant, it happens. I had a lady had to get her gallbladder out while she was pregnant, because she was that sick. So they're still patients too. You still have to take care of their medical illnesses. All right. That's all for that. You guys want to take a quick potty break? Okay.